So this is me. I am an assistant professor. I recently completed my residency in emergency medicine at Queen's University in Canada. So I work in the emergency department. I'm a trauma physician, and I work on the RACE team, which is the team that deals with acute resuscitations and acute illnesses in the hospital as well. Some hospitals refer to it as a critical care outreach team. A little bit more about myself. These are my two boys. In the back there's Joseph, the older one, and in the front is Jack, the younger son. They're what keeps me sort of motivated and ensures that I have a good work-life balance. And about work, this is where I live. This is Kingston, Ontario, which is a small city between Toronto and Montreal. And my hospital is right at the end of that arrow over there. So that's where I work, and that's where I am right now. Okay. So the next question is, why resuscitation medicine? Why is resuscitation medicine interesting? Why is expertise research in resuscitation medicine of value? So what I would suggest is that what makes resuscitation medicine research interesting is, number one, that the stakes are high. It's a very complex medical environment. There's many decisions to be made, and one of the very interesting aspects of what we do is crisis resource management. Decision-making, leadership, all under time pressure and clinical pressure. There's little that's known about expertise development in our particular setting. There's a lot of expertise research out there in other settings, but it seems that not many people have really looked to resuscitation medicine. And the other interesting part is that as I've been going through my training, it's always been interesting that you can identify someone who is really good at being a team leader in resuscitation. But it's actually quite difficult to really explain what makes them expert, what makes them particularly good in that environment itself, despite the fact that you can see it. And if you interview these people afterwards, they actually have a very difficult time explaining what made them particularly good or particularly effective. A lot of this expertise that they have is quite tacit, and it's, again, very difficult to teach. Now, I should take a step back and just explain what I mean by resuscitation medicine. People who aren't in the field maybe think of resuscitation medicine as purely CPR for patients who don't have a pulse. It's a little bit more broad than that. That's certainly part of what we do, but we also help manage and deal with patients who are acutely ill for a variety of reasons. But generally, these are patient interactions that are a little bit more high stakes with a lot of people involved. It's not uncommon to have 10, 20, 25 people in a room looking after a patient like this. So that sort of sets the stage as to why resuscitation medicine. So the theoretical starting point. So again, having just completed my medical training, I remember being the physician on the left-hand side there that you can see. So the physician who's frazzled, who is trying to deal with a difficult situation that has a lot of competing priorities and perhaps is not that effective. Whereas turning to some of my more senior colleagues with a much more calm demeanor who can explain things in an effective way and who probably provide much better patient care. And so watching myself over these years led me to sort of think about what makes someone an expert in this field and what makes somebody good. So in terms of the theory, we talk about expertise development, cognitive load, which is related to working memory, expert behaviors. So I've already mentioned that those with more experience and expertise have different outwardly behaviors. And finally, how this all ties into learner assessment, which is where my academic hat comes in. Can we predict or can we assess people in novel and different ways based on their performance as they develop expertise? I'm going to just go over a little bit of a theoretical framework for the PhD proposal, or for the PhD project, I guess, as a whole, and then I'll explain how each of the studies fits into this outline. So there's the expertise development continuum from novice to expert left to right on your screen there. And then there's competence somewhere along that spectrum. I think it's difficult to really say exactly where competence is, and with the new competency-based medical education system that's being mandated in Canada and many other jurisdictions, this becomes quite relevant. I would suggest that cognitive load or mental effort on a particular task starts out as quite large for a particular task for a novice, and then it diminishes with time. As you can see, the triangle sort of gets more narrow with experience, expertise, and time. On the other hand, expert behaviors, as a novice you don't have many of these behaviors, and I use the term behavior quite loosely to mean crisis resource management behaviors, cognitive behaviors, decision-making behaviors. And as someone develops more expertise, they gain more and more of these behaviors and look more expert-like. In our project, we're measuring cognitive load with cognitive load measurement instruments, so pupillometry and psychometric surveys, which we'll get into in a few minutes. And on the flip side, with the expert behaviors, we measure expert behaviors with eye tracking measures, looking at team dynamics and leadership, and then a new area is looking at reflections and how this relates as well. All this informs learner assessment, and I would suggest that this informs learner assessment to a greater degree, or perhaps a different degree, compared to traditional assessment modalities, which generally consist of either multiple choice or short answer questions on examinations, or expert grading in a clinical context. And we all know how all of those modalities are flawed inherently to a certain degree. So the research question. So I'll go into the 5 studies. In study 1, we looked at cognitive load as measured by task-evoked pupillary responses with an eye tracking device. And some of the background literature suggests that changes in pupil size are correlated with changes in cognitive processing demands, and the magnitude of that particular change is a pretty good marker of what we think represents cognitive load. So just to explain what I mean by that, in case you're not familiar with this this literature, cognitive load is colloquially thought of as how hard someone is thinking. So if I ask you what the answer to this arithmetic question is, I think most people would be able to answer it quickly. Alternatively, if I ask you this one of 2 things would happen. You might think about it really, really hard, eventually perhaps getting the right answer, or you may say, you know, that's too hard, I'm not going to think about it at all. But I can tell you what your pupil does during those times. So with the first question, this is more or less what your pupil looks like, and with the more difficult question, if you do put the effort into trying to answer it, your pupil increases to a predictable level. So the research question is, does cognitive load, as measured by these pupillary techniques that I just described, does that differ between novices and experts when answering resuscitation medicine examination questions? So again, this fits into this part of the theoretical framework. This is purely cognitive load measurement, and this is looking more at the theoretical side, at the assessment side, as opposed to the in situ, true resuscitation medicine clinical environment. This is the beginning. So I presented some of this work at a few conferences, and people always ask, how do you know you're measuring what you think you're measuring? Is there a true construct validity to what you're doing? Are you measuring cognitive load, or are you measuring something else, perhaps stress or something along those lines? So in the second study, what we're proposing is looking at physiological markers of cognitive load, i.e. the pupillometry that I just described, compared to some psychometric measures that are thought to represent cognitive load as well. So there are some good, well-validated psychometric questionnaires that aim to look specifically at cognitive load measurement. And in this study, what we've done is we've looked at the pupillometric measures as well as the psychometric measures to see whether or not there was a correlation and whether or not we could argue that there was construct validity to the pupillometry research in resuscitation medicine question answering. So this I've already described, but the research question is there a relationship between the physiological and psychometric measures? Essentially, is there construct validity? Basically, are we measuring what we think we're measuring? That's the second study. And the second study fits in, again, up here into the theoretical framework between these 2 types of cognitive load measurement. The third study is also related to the first 2. A little bit of background. Cognitive load is thought to be comprised of 3 basic elements. There's intrinsic cognitive load, and that refers to the complexity of information. Extraneous cognitive load, and that's suboptimal information presentation conditions or other extraneous factors. And there's germane cognitive load, which is thought to refer to the working memory that is dedicated to processing the first type of cognitive load, so that intrinsic cognitive load. In this study, what we are proposing to do is, again, looking at traditional multiple choice testing, what proportion of cognitive load is due to each of those subtypes of cognitive load. And we're also looking to see if learner motivation and also stress and tension, whether or not those whether those modalities or those variables also confound the results of cognitive load measurements. And again, there are some collaborators actually from Maastricht University who have created some excellent tools to try to differentiate these types of cognitive loads, and those are the ones that we're using in this study. So again, study 3 fits into this cognitive load piece up here at the top of the figure, as you can see. Moving now down to the bottom of the figure, this expert behavior area, we're now looking at eye tracking. So now we're taking a little bit of a step away from the theoretical classroom examination format, and we're looking more at in situ, at least in simulation, management of medical emergencies. So we have residents of all levels of training, from some medical students, some junior residents, mid-residents, and then senior residents, as well as some new faculty who have graduated from their examinations already. And we put them into a simulated medical environment, a medical crisis situation, where they have to manage a patient with a large team with them. Again, these are simulated environments. And we place eye tracking glasses on them, and we can see where they're looking in those scenarios. And in this study, this is an exploratory study, and the question that we're looking at is whether or not there are specific things or areas of interest that junior learners versus senior experts look at differently. So some of the expertise research suggests that experts know what is relevant in a scenario, whereas novices do not know what is relevant in a scenario. And looking at some of the preliminary data that we've started to get out of this study, is we're finding that indeed experts really know what is relevant, spend more time looking at those areas, whereas the novices have a bit more of a diffuse visual gaze pattern, and they're not quite as effective at what they do. We're comparing our eye tracking, gaze tracking measures to blinded outside expert observers who are also grading these the performances from these learners on validated assessment sheets. So again, in medical simulation, OSCEs, do resident gaze patterns differ with respect to blinded expert-rated performance? And then can we predict performance if we know where physician leaders are focusing their attention? So if I can tell you that a particular physician focused a lot on an ECG in a trauma case, for example, could I then predict, or how much of that person's performance could I predict based on knowing how much time they looked at that ECG, for example? I give that example specifically because an ECG is rarely relevant in a trauma case. So we're finding that our expert physicians don't spend a lot of time looking at that, whereas the novices comparably do. So again, study 4 fits down here at the bottom within the expert behaviors context of this study. The next study, again, is focusing in that bottom area of the graphic. There's a lot of research that considers the effectiveness of decision-making during clinical settings through eye tracking, as I've explained, some think aloud protocols and video recording. We are repeating study 4 in a slightly different way. We're going to have rubric-based prediction and reflection forms for learners before and after their sitting. And we're going to be looking to see whether or not they can predict their performance, predict their where they need to improve. And we're going to combine this with eye tracking methodologies as well as feedback, looking at eye tracking data from particular residents to see if we can identify gaps that the residents have, and then try to facilitate reflection and lead to improved performance during subsequent examinations. And finally, one of the other questions is, can we use these methods to assess and then track expertise over time with these residents who are with us for a number of years? So again, this is a very quick overview of what's going on, and there are obviously more details that I can get into. So again, study 5 fits into the expert behaviors context at the bottom here, and that's where we're focusing on that today. We will be focusing on that today. So the basic premise of all this is expertise development. How do we go from being a ineffective, frazzled junior learner to then becoming expert in, well, any field, but specifically resuscitation medicine? What are the milestones that happen? Can those milestones inform entrustable professional activities in a competency-based medical education system? Are we able to move people from novice to expert more quickly if we know what is going on during this expertise development continuum that's sort of natural and happens with time? So those are the questions that we're trying to answer. Generally, we want to better understand this expertise development process. A couple of thank yous. Dan Howes has been my mentor and friend here, who's my collaborator here on site. My supervisor, Dr. Van Marion Boer, and co-supervisor, Andreas Gegenfertner, as well as Jimmy from Maastricht, as well as medical students and residents who have been collaborating on this project and other projects over the last few years. It's a large team, and this is certainly not a one-person effort. So thank you, and I'll open the floor to any questions.